Spring ligament. Yes. So you have this calcaneonavicular ligament. That's why when you look at a foot that doesn't have that pes planus or too high of an arch, they have a little bit of a curve in that arch, which is higher than the lateral arch, the tarsal, the arch, and the metatarsal arch. So that makes sense to you.
Is this going to be online?
Yes, I'll put it up for you guys. So again, what makes up the medial longitudinal arch is going to be the calcaneus. So the medial border of the calcaneus and navicular. So in some kids, when they're young, you'll see like their navicular really stick out. So that's something associated with like a growth plate abnormality. You have the medial cuneiform, so the three cuneiforms of the tarsal bones in the foot, and then your spring ligament. So that's what makes up that arch. So muscles and movements of the foot. So responsible for that dorsiflexion. So when we talk about it, toes to your nose, you have that tibialis anterior, extensor digitorum longus, extensor hallucis longus. So what's the difference between digitorum and hallucis?
Big toe.
Good. So digitorum is all the digits. So again, I know that easy way to remember this is if you think of extension of the toes, that's as simple and easy as dorsiflexion. It's just dorsiflexion is another name, so it's the name for that movement of the entire ankle. But extension of the toes could be considered dorsiflexion too, because you do it all together. So that's why all of these muscles work to dorsiflex. And then your peroneus tertius. So we talked about the peroneals and how you have that one abnormal peroneus muscle that doesn't work with the rest. So that's the peroneus tertius. And if you guys can go in a book and look at this to help for you to help study, for studying purposes, the peroneus tertius is actually an extension off of that extensor digitorum longus. So that muscle spans off of it and attaches down at the styloid process of the fifth metatarsals. So how to remember it is knowing it has association with the extensor digitorum. So that's what makes it different than all the other peroneal muscles. Okay? So plantar flexion. When we talk about this, we're also going to bring in the compartments. So dorsiflexion occurs in what compartment of the lower leg? So now we're not just talking about the ankle, we're talking about the whole compartments. So splitting the leg in half and looking, there's compartments. What compartment is responsible for dorsiflexion?
Anterior.
Good. Please remember that. So anterior compartment. So if you have damage to the anterior compartment, you're going to have limited dorsiflexion. Okay? Plantar flexion. What compartments are associated with plantar flexion?
Posterior.
Posterior, and there's two. So what are they known as? For the posterior.
Superficial or deep?
Good. So again, you need to know what muscles are in each. And I didn't bring up the very deep posterior in this. So plantar flexion, the superficial posterior compartment is the gastroc consolius, okay? And then when you get to the deep, you're going to have the flexor digitorum and the flexor hallucis and the posterior tibialis. So that's the deep posterior compartment. But they all work together to do what? Good. Good. So peroneus longus and peroneus brevis also plantar flex, but their main action is aversion. And what compartment are those two located in? Good. I'm glad you guys are picking up on it. So, if somebody, yes. Inversion has some, it's not one of the primary movements, but you have the anterior tibialis and the posterior tibialis working to do some inversion as well. But mainly, I just want you to know the compartments, and that's not really brushed up on in the compartments. So, inversion is an accessory movement from the posterior tib and the anterior tib. Okay, so could I have a volunteer, because I'm going to show you some special tests.
These are the things I asked her. This is all the things I asked her the thing before. Freaking crazy. Yeah, the stuff before and then these things.
All the way down.
Yeah.
She's so awesome.
Okay, so starting off with percussion and compression tests. So what do you guys think these special tests are? Fractures. So okay, so you can do these in a lot of places. So to talk about percussion, we talked about Ottawa ankle rules. So these are some of the stuff that you'll do in an assessment or an evaluation of ankles. So to do medial and lateral malleolas, so they would say, especially in young adolescents, if they're real pain and point tender on the medial and lateral malleoli, that's a sign of fracture. So a percussion test, it would be simple and easy. It would just be tapping. So they will, a lot of times, scream out in pain if it could be an avulsion fracture to that area. In younger kids, it could be a growth plate related fracture. So you're just gonna percuss on the area. So that's known as percussion. You can do it in a lot of places. So just tapping on different areas. So a lot of times people will do it on the navicular. You can do it on the styloid of the fifth. So that's just an example of percussion. The most common place you'll see people tap on the ankle are going to be those malleoli to make sure that there's not a fracture. So compression tests. So this is another one. So again, this one you'll see very positive in people who have possible stress fractures. Oftentimes it's muscular related. So it could be an overactive posterior tibialis in people running constantly downhill. So you're just gonna compress the tib and the fib together. So a lot of times a person will scream through the roof in pain. So sometimes if it's just one of those tests being positive, and not the other, then you can kind of be like, well, let's give it a few days and see if it's just muscular. So give them a couple days, kind of relax and see if it's more muscular and not bony. So another one, person goes down and really rolls their ankle and they can't walk on it. That's another Ottawa sign. So they're unable to take one single step on it. So you also have the bump test. So don't forget about this one testing for fracture too. So that's just taking the foot and bumping. So what it would do is send sharp shooting pain up through the tibia or fibula, whatever one's fractured, it would send kind of a jolt of pain. So when you're bumping, you want to make sure you bump really hard because you're trying to test for a fracture. Okay, so Thompson test. Could you flip on your belly? So Thompson test is the person says, it feels like I got kicked in the back of the ankle. So we talk about those Achilles tendon ruptures. They don't happen a lot in younger individuals. It's usually those weekend warriors, 50-year-olds who think that they can play tennis like pros. So to test for this one, you're just going to squeeze. So do you guys see how her foot is plantar flexing? If you have somebody who has a complete rupture, that would not be happening. So as you see, her foot plantar flexes as you squeeze. So positive test is going to be that foot wouldn't be doing that movement, or another positive test, you're going to see it rolled up. So the Achilles tendon oftentimes will go off the distal attachment and roll up into the upper portion of that foot. Okay, so anterior drawer, so go ahead and flip back around. Yes?
Does that also include like this only total rupture of 18 or can it include partial?
So comparing bilateral, if you're noticing one have a lot more movement than the other, what could it possibly be? Yeah, so again, everything always wanting to compare bilaterally. So when you're checking and you're saying, oh, they have a little bit of movement, but it's not what it was in the other one, then it could be partial. Okay, so I will show you two versions of anterior drawer. So I got taught the one in undergrad. This one's not in the book. So anterior drawer of the ankle. Which ligament of the lateral ankle is anterior drawer mainly testing for? I know it tests for all of them.
ACL.
ATF. Good.
ATF.
Okay. Yeah. Knee, ACL. It's the same
sorry.
test. But for the ankle purposes, it's the anterior talofibular ligament, and that's because in a closed chain, it prevents the backwards translation of the fibula. So posterior translation. So in the open chain, you're not going to see it doing that, but with it closed, in the closed chain, to make that make sense to you guys, that's with the foot planted. It's preventing the fibula from sliding posterior. So this is the one that I like to teach people. This is the one that I got taught in undergrad, and I've gotten more positive tests on this one than the actual one in the book. So you hold and stabilize the foot, and you're just going to push back on the fibula. Positive tests when comparing bilaterally would be the translation of the foot back pain. They're going to grimace. They're going to say, ooh, that's really, really painful. That hurts. So laxity is what you're looking for. So obviously, if I only do it on this side and say, oh yeah, that causes pain, that's positive. That's not true, because you're going to want to check this side too to make sure that, oh, this side is way more lax. So you definitely have something going on with that ligament. So the other one, if you want to sit up for me, to the edge. It's similar in nature. It's just stabilizing the tib and the fib, and you're going to do the same thing, holding the calcaneus, sliding it forward, and again, looking for laxity. Okay, that one feels a little more lax, which is I believe her. It's just one. Oh, interesting. Okay, Homan's sign is the next one on here. So Homan's is just going to be testing for deep vein thrombosis. So it's just squeezing the back of the calf and plantar flexing. So if you guys remember, this is the one of the blood clot. You probably won't be doing this much in the young active population, but it's just testing for DVT. So this is the one we talked about. It's a medical emergency. So thrombosis is a blood clot forming. So in the artery, in the vein in this circumstance. So again, medical emergency, you want to rule out the difference between Thompson and Homan's. So Homan's more associated with vasculature, okay?
How did you say you see a positive test on that one?
Homan's, this is more in the older
Yeah.
individuals. First off, they'll be complaining of Dolly-Key pain, which you first would relate to a muscle strain. You would think it's a muscle strain of the gastrocnemius, but they didn't really do much activity. So they aren't really going out. So my friend got it in her hip, and she played dodgeball for a weekend, and she was like, it wasn't crazy, like I wasn't really doing a lot, and I was sore for 4 days straight, and it was like excruciating sore. I couldn't figure it out. So it's just a chronic, dull, aching, lagging pain without activity too. So that clot is going to cause excruciating more pain when you plantar flex and kind of squeeze.
Okay, so you're just seeing their
Yeah.
pain response.
Pain response.
Okay.
Okay.
So. Okay, Taylor tilt. Go ahead and go on. So Taylor tilt is simple and easy. You're gonna hold around the calcaneus. And what does Taylor tilt test for? For when you're pulling into eversion, what's it testing for? What type of spring? Eversion. So what ligament? Good. So again, you don't have to memorize all 5 of the deltoid. I know that's a lot. But again, deltoid ligament sprain when you pull into eversion and they're like, ooh, that hurts. Inversion, so Taylor tilt and inversion. What one is this testing?
For the
Lateral, but one specifically.
spring? Anterior?
So
Or the
anterior drawer is for,
Oh, okay, so the
yeah, so calcaneal fibular is for the Taylor tilt for inversion, okay? So mainly calcaneal fibular, but yes, all of them. But on an exam, I would say, what ligament is mainly being stressed with Claggers? Taylor tilt, sorry, okay? Claggers is next. So this one is similar in nature, but it's testing more for high ankle sprain, okay? So what you're gonna be doing is putting the foot in semi-dorsiflexion and then into external rotation, okay? So this can stress the deltoid some, but also if they start to feel kind of pain more up in here, it could be more associated with a syndesmotic sprain, okay? What?
If it's the high ankle sprain, what ligament is that?
Oh, I'm getting to it. Okay. So, which ankle sprain is more common? 90% of them are what?
inversion.
Inversion, lateral ankle sprains. Okay, so can you guys tell me the 3 different types of ankle sprains? Inversion,
Eversion.
eversion, what's the third one?
Eversion.
So you have inversion, eversion, high ankle. Inversion is going to be vulnerability, injury to the anterior talofibular, calcaneal fibular, and the posterior talofibular, okay? Eversion is going to be injury to the deltoid, and then that high ankle. So to talk about this one is the foot in dorsiflexion and hard external rotation. So you'll see this happen in football where the person falls down and somebody hits their foot and forces it into external rotation. So this is usually damage to the syndesmosis, and also you'll see possibly an eversion and a lateral ankle sprain with it as well. So it could be damage to even the lower ligaments. But with these 2, like you asked, the 2 ligaments associated with high ankle sprains are going to be the anterior and posterior tibiofibular ligament. Okay, so if you remember
Are
and
those the
learn,
syndesmotic ones?
yes, syndesmotic is anterior and posterior tibiofibular. If you learn where the tarsal bones are, you're gonna remember the difference between talofibular and tibiofibular. Because all of those ligaments are attached to the talus. Okay, so that's how you can remember it. Study your bones, and then it's easy to remember those ligaments. Because I don't necessarily normally make you guys memorize every single ligament in the foot. There's a ton, but you do need to know these because it's very specific to injuries. Okay, so you asked me to address pronation and supination.
She's
This
so
stuff
good.
is hard. This is stuff that I studied an entire semester in biomechanics, so I don't expect you to be geniuses because I'm so confused about it. So please understand that when you're like, oh, can we go over this again? I was like, crap, because I hate it too. But I'm gonna go over the basics so that you guys know what you need to know for the test, okay? So pronation, this is gonna be more associated with someone with flat foot. That being the subtalar joint is loose in nature, okay? So this is someone having a loose foot. So when we talk about this, what did I talk about previously in class? Injuries with flat feet are more commonly what structures?
Soft tissue.
Good. So again, it's because that foot is loose, putting stress to more soft tissue structures, not so much bony. The bones aren't rigid. It's more tense and more intense injuries happening to the soft tissue structures. The first metatarsal and the first cuneiform are more mobile in nature, okay? So that's more pronation. Supination is dealing with those higher arch people. So again, these are foot conditions, but flat feet more associated with people who pronate, supinating being associated with people with high arches. So these people have a hypermobile mobile foot. So it's not allowing that mid-tarsal joint to unlock. So what it's causing is mobility of the first leg, okay? So talking about the different structural deformities. So reading in the book, you're not going to notice these structural deformities as much when that person's weight bearing. You're going to notice them more with the foot just non-weight bearing. So having them sit and having their foot hanging off of the table, these are where you're going to notice these, okay? So these exist in a non-weight bearing position. So structural forefoot varus and rear foot varus deformities are associated with pronation. So structural forefoot varus being the most common. And when you ask what the difference between these are, it's location. So rear foot being the back of the foot, forefoot being in the mid region of the foot. Structural forefoot valgus is associated with excessive supination. So when I'm showing you the next slide here,
That's non-weight bearing.
no, the way that's up. So I only need the first set, so that's good. So forefoot and rear foot varus being associated with pronation, forefoot valgus, supination. So the best way to remember is if you can figure out these lines and how they are, it's going to help you remember what type of plantation that you're going to need. So what type of wedge do you think forefoot or rear foot varus is going to need? What are you seeing? Versus this. These are on the lateral side, these both being medially. You're seeing the first foot being,
Also medial wedge.
yes.
Oh, okay.
So to help you remember, again, you're going to be examining this, having that person subtalar neutral. So that would be making sure that the talus is even on both sides. So subtalar neutral, for example, would be me putting pressure on the talus and moving the foot so that I have even pressure on both sides of the talus. So that's what you'd put them in, sitting off the side. And then you would be looking for forefoot varus or rear foot varus. Both these needing a medial wedge because of the way the forefoot's inverted or the calcaneus inverted. So does that make sense to you as why one is inverted, not the other? This one being forefoot, so the forefoot's going to be inverted, and forefoot varus. And rear foot varus, the calcaneus is going to be inverted because it's dealing with the rear of the foot.
Okay.
That
And that's just a
forefoot-
structural thing, or is it?
Yes.
Okay.
So with weight bearing, this is when stuff is going to happen. As in, you might start seeing flat feet, people who supinate, turning with their toes out. You're not going to see this so much in the weight bearing. This is just looking at them in subtalar, neutral, non-weight bearing. And this is what you'll say, possibly because your rear foot varus and your forefoot varus, you might need a medial wedge. That might help with your injuries. So this is something you can use in your objective before even touching anything. They're coming to you with shin splits. They're coming to you, yes. So pronated, structural forefoot varus and rear foot deformities varus are associated with pronation. So varus is pronation, valgus supination. So again, rear foot and forefoot varus are associated with pronation. Forefoot valgus is associated with supination. And if you look at the picture, you will understand what kind of wedge is needed for each because of the way the foot. You want to put that cushion where that's occurring. So it's cushioning. So you're not putting, so for this one, for example, you're not putting too much impact on the lateral side of the foot when you put a cushion in. You're allowing for more absorption throughout the entire foot. Does that make sense to you? So overall, no rear foot varus, forefoot varus are associated with what? Pronation. Okay. Rear foot valgus associated with supination. Flat feet are associated with what? Pronation. High arches associated. You're gonna get into intense biomechanics in a few years. So good luck with that. Okay. So talking about special tests, these are additional special tests, okay? So testing for hip flexor tightness, so known as Thomas test, okay? So what's the difference between Thompson and Thomas?
Thompson is for the.
Good. Please know the difference between those two. So Thomas test, simple and easy. Could you come to the very end of the table? You go ahead and just walk right off it for me, and then you're just gonna put your butt right down on it, and then lay back. For this one, in the book they show you with a person lying completely prone on the table. So hold your knees for me. Okay? And again, checking bilaterally. So what you're gonna do is just drop this one leg. Yep. And just relax your knee. Okay, so you have a tight IT band for sure, but what you're looking for is if a person has really tight hip flexor tightness, you seem to be kind of okay. Yours isn't too bad, but it would be higher up. Does that make sense? Because of the tightness in the hip. So what is the hip flexor? You guys remember what muscle that's called?
TFL.
No, it's TFL is associated with abduction. Iliopsoas, good. So that's the hip flexor muscle. So again, it would be very, very, if it's tight, you would see it higher up. So again, you can compare bilaterally. So go ahead and drop this one. So seeing if one side's tighter than the other, but you're always going to be wanting to check hip flexors and hamstrings to see is one of these inflexible to the other, okay? So that's hip flexor. So test for sacroiliac joint pain, the only one we really talked about was Faber. So go ahead and lie back a little further. So being the posterior superior iliac spine, the two dimple muscles we talked about in last class, we're not going to be talking a lot about the lower back. This is just one that's mentioned due to the fact we talked about the pelvis. We'll be talking more about the spine later on. So you're going to learn this test again, and the extra additional ones. So what you do is put the person in a figure 4, just like this, and you're going to hold down or compress the opposite side that you're doing the figure 4 in. So it's called Faber because you're putting the person into abduction. So flexion of the knee. So flexion and abduction. So Faber and external rotation of the hip. That's why it's called Faber. And what you're just going to be doing is pushing down on the knee. So what this test is testing for is pain in the sacroiliac joint. So back in those dimples. So again, you would, if they're coming in complaining of back pain, you're going to do both sides because you're going to see if one joint is more sore than the other. Okay? So there's for that one. For IT band tightness, you're going to have Renee's, Nobles, and Ogres. So I'll do Ogres for you first, just because then you don't have to get off the table. So go ahead and flip on your side. No matter which side. Either side. Well, this side would be better, so flip that way. So face them, yeah. Okay, so go ahead and bring your butt like completely into me, just like that. So OBRS is testing for IT band tightness, and this one can also be used for your advantage because you can put it the IT band at a stretch. So when I talked about it in class the other day, when I said you need to clear the greater trochanter, when I do this one, I'll bring the hip up and around to clear it out. What you do is simply just drop the leg. So test for this, checking bilaterally if they're having pain in the IT band, would be if it's forced kind of not going down very far. So you'll see them kind of staying up with their hip. So for example, let me kind of push this. Do you feel a good stretch going up through your IT band here?
Yeah.
So again, this is a good, clinically, OBRS test is a great stretch that you can perform to the person too. So if you put their foot back into further extension too, and then push down, you'll get a better stretch. So again, checking bilaterally if they're, sometimes you can just feel an IT band too, to diagnose that it has a lot of tightness. So just feeling it and noticing bilaterally when feeling the IT band that one side's a lot tighter than the other, it could be a sign of why that person has knee pain. Because when we talked about the IT band, it goes a whole way down the leg and attaches in on Gertie's tubercle. So sometimes they'll have knee pain, and when you palpate throughout the area, that will cause a lot of pain. So that's a good diagnosis for it too. So go ahead and lay on your back. Bring your knee, both knees up. Nobles is the same thing. You just kind of palpate on the lateral condyle of the femur. And put the foot up into extension and back down into flexion. If they have pain over that lateral condyle, it's a sign for it. The other one is just, I'll do it so you don't have to get up. Renee's, I've never really used this one. I just learned from it in the book. Is again palpating lateral condyle and just bending. So if they have pain located through here, it could be a sign that it's IT band. Anyone have questions on those? So I spoke to one of the students about this previously. I'm not going to put on the exam. You put the person lying prone, and you're going to put the knee into flexion and have them resist. I'm not going to have questions like that. More of the questions are going to be based on what is Thomas test testing for. So does that make sense to you?
Yeah.
I don't want you to know the exact procedures. It's just, we're going to get into this one of these days, then so you know. So I didn't get to finish through those, so go ahead and use them to your advantage, and I can